Okay, we'll start now, Doctor.
Yep.
Good afternoon, everyone. Welcome to Geriatric 1. Today's topic is continence, how to assess and approach. Speaker for today is Dr. Lim Wan Che, geriatrician from Hospital Taiping, and our chairperson is Dr. Lau Chun Ming, consultant geriatrician from Sunway Medical Center, Penang. Dr. Lau Chun Ming is currently practicing in Sunway Medical Center, Penang. He received his training in various centers in Malaysia, as well as Royal Perth Hospital in Perth. He is currently active dementia caregiver trainer for Alzheimer's disease Foundation Malaysia, and sits as a council member for Fragility Fracture Network Malaysia. Without further ado, let's welcome Dr. Lau Chun Ming.
Thank you, Dr. Priscilla, and thank you everyone for joining today in what I expect to be a very exciting talk by my friend and colleague, Dr. Lim Wan Che. Gives me great honor to introduce Dr. Lim. Dr. Lim Wan Che obtained his medical degree from International Medical University back in 2010, and then completed his membership from the Royal College of Physicians in 2015. Subsequently, he completed his subspecialty training in geriatric medicine in 2021. Dr. Lim has served in various hospitals throughout Malaysia and is currently serving as the geriatrician in Hospital Taiping, meanwhile leading the orthogeriatric service there as well. He is a member of various professional bodies, as well as having published extensively in both local and international journals. Gives me great honor to invite Dr. Lim to present his talk to us. Thank you.
Thank you, Dr. Lau. I just noticed my name is spelled wrongly, but it is probably it's my login. I didn't type my own name correctly, so it's WAN. Anyway, I think I'll get to it. I'll share the slides right now. Okay, so the topic of my talk today is continence, how to assess and approach. So let's get to it. Okay, let's get to it. So basically, when we are talking about continence, I think we are talking about incontinence, right? The inability to control excretory functions, because the opposite of that would be continence, right? The ability to control excretory functions. But the main focus of my talk today will be on incontinence. And actually, incontinence is not just urinary; it can also be fecal, and it can also happen with both urinary and fecal incontinence. And this happens at any age, right? Imagine from the very young age, right? During the neonatal period, all the way up to adulthood. And etiology is multifactorial. Now, when it comes to geriatrics, right? Older adults, this is a very important syndrome because it's one of the what we call frailty syndromes. So what are these frailty syndromes? These are things that tell us that patients, may have frailty and may require further evaluation to elucidate what the causes are, because they are usually multifactorial. So yes, incontinence is one of the frailty syndromes. And I will start with urinary incontinence. Actually, the bulk of my talk will be on urinary incontinence, with just a little mention of fecal incontinence at the end. And we'll start with an introduction. As we all may be aware, or if we need to refresh, urinary incontinence, we basically divide into types. There's stress incontinence, urge incontinence, mixed incontinence, overflow incontinence, functional incontinence, and others, right? So in stress incontinence, the problem is too little tone, right, at the bladder outlet. And with urge incontinence, there is too much activity of the bladder muscles, which causes urine leak. And in overflow incontinence is when you can't hold the urine anymore. Anyway, again, stress incontinence is the involuntary loss of urine which happens when, there's pressure coming from the abdomen. And this can happen when you laugh or when you cough or, when you're carrying heavy objects or even when you're climbing things, And so this happens because normally in a normal bladder, there is sufficient tone at the bladder outlet given by the, pelvic floor muscles and also the bladder sphincter muscles itself to keep the urethra closed when even when there's a rise in pressure. But for various reasons, this outlet may be weakened, and therefore, during periods of abdominal pressure, increased abdominal pressure, urine leaks out. That's stress incontinence. And urge incontinence is due to involuntary leakage of urine, which is preceded by a sudden desire to urinate, which may come suddenly without any warning. And it is usually due to bladder activity. The bladder is contracting against the closed urethra, and before even the bladder is full. And so it causes the sudden urge to want to urinate. And if you do not reach the toilet in time, you may leak. And overflow incontinence is not due to a full bladder, which may be due to urinary retention for various reasons. For example, in patients with benign prostatic hyperplasia, when the bladder is overfull and it can't expand anymore, then some urine leaks out because there's just nowhere else for the urine to go into. And the cause of this problem is usually a bladder outlet obstruction. And functional incontinence is not due to any of the factors listed previously, although it may be, it is due to the inability to reach the toilet in time, the place where you can pass urine. And this may be due to various factors, physical factors, functional factors, mobility factors, or cognitive factors. And finally, we have mixed incontinence, which typically people say is a combination of stress and urge incontinence, but really it's just a combination of different types of incontinence. So you can have the various types of incontinence mentioned above mixing in a patient. And incontinence is actually quite prevalent because of multiple studies with multiple methodologies. There is a lot of variation in reported prevalence. It's about 5 to 70%, but most studies say it's around 25 to 45% in the older adults. The prevalence increases with age, as you can see here, and women are more likely to develop urinary incontinence than men. And the most common types of incontinence, urinary incontinence, it goes stress incontinence followed by mixed incontinence and urge incontinence. And in older women, there is more urge and mixed incontinence. And incontinence, as I mentioned earlier, being that of a hallmark of geriatric syndromes, has a higher incidence in not just older people, but also in institutionalized patients. And in Malaysia, we actually have the National Health and Morbidity Survey in 2018, which reported the prevalence of incontinence as between, and also some local studies, is about 22.9% to 9.9%. And also it shows the same pattern that we talked about earlier, which is that women suffer it more than men and so on. And these are the risk factors for incontinence. General risk factors would be increasing age, as we mentioned earlier, impact mobility or impact cognition. And for men specifically, the presence of BPH, hypertension, and also a history of urinary tract procedures and major depression increases risk. And for women, all these factors which we more or less expect, parity, vaginal delivery, hysterectomy, things that may weaken the pelvic floor muscles, high BMI, family history, and also history of oral HRT, and also diabetes mellitus. These are the risk factors. And medication actually plays a large role when it comes to urinary incontinence. So medicine or things that may increase the risk of incontinence, urge incontinence would be things like diuretics or alcohol. And for stress incontinence, it would be things like ACE inhibitor or alpha blockers. And for overflow incontinence, many types of drugs which may cause urinary retention, anticholinergics, calcium channel blocker, opioids, antihistamines, anticholinergics, anti-Parkinson drugs, and alcohol. And of course, there's a lot of things that incontinence, causes, it causes a lot of physical issues like discomfort. It may increase the risk of pressure ulcers, it can cause skin breakage, and it can actually soil the surrounding environment, right? And increase falls risk. It's also very embarrassing because incontinence can occur in the people who are functioning well in the community, and as it is a source of embarrassment, right? It may cause people to shy away from going out or attending social activities, and it may also impair sexual function. And of course, when you shy away from going outside, right, activities, right, you also then have to take more time off work, or you also have to spend money on incontinence care or doctor visits, and that increases the cost of medical care. And socially, of course, it reduces intimacy with people and loved ones, and also increases carer burden, especially for people who have to attend to those suffering from incontinence, and it increases the chance that someone may be admitted to a nursing home, and discourages people from traveling. And so the talk is actually on the approach towards continence. So next, we want to talk about evaluation of urinary incontinence. And as with any other forms of evaluation, it starts with history taking. And with history taking, we actually want to elucidate or try to determine what is the type of incontinence that patient may be suffering from. And symptoms may be divided into that of storage issues like frequency, urgency, nocturia, or stress incontinence, or voiding issues, things like post-micturition dribble, hesitancy, terminal dribbling, incomplete emptying, or incomplete scream, which you would expect in patients with lower urinary tract symptoms, men with BPH. And from there also, there are important things that you want to determine. The medication evaluation, for example, because medications, one of the major causes of incontinence, surgical history, obstetric and gynecological history, and cognition and function and mobility. Because if you recall, function and mobility and cognitive issues may also lead to what we call functional incontinence. During this process, you want to also pick up signs or symptoms that may suggest that patients require rapid evaluation. And that would be things like, pain, hematuria, history of recurrent UTI, history of prostate, pelvic surgery, radiotherapy, or if there's a constant leak. Yeah, I wrote that twice, sorry. And then on physical examination, you want to focus on abdomen and the perineum. And also you want to examine do a per-rectal examination. You want to look at the prostate. And in the pelvis, you want to look for signs of a vaginal organ or pelvic organ prolapse, which may be a source of incontinence in women. And what about other tools that can help us to detect or diagnose incontinence? Actually, there are various tools out there. Lots of them are validated. And by validated, I mean that they are valid. Valid means, they give results which are precise, and reliable means that they are reproducible. And responsive. Responsive means that it is sensitive to any changes in the symptoms. So all these questionnaires that are listed here are valid and reproducible, and also sensitive to change. But the thing is that they assess different things. Some may assess the symptoms, some may assess satisfaction. And are they useful in diagnosing certain types of incontinence? Some more than others, but none are are capable of properly differentiating between these types of different types of incontinence. It still falls onto us to make that evaluation and assessment. But for use in clinics, another use may be to look for sensitivity to change, right? Many results or to determine the outcome of treatment. So if you choose to use questionnaires, choose those that are validated from the list here. And you need to determine what the utility of the assessment tool is, whether you want to use it for treatment monitoring, or whether you want to use it for screening, or you want to use it for diagnosis. And another thing that we do to assess incontinence is what we call post-residual volume evaluation. When patients have passed urine, you assess for any residual urine in the bladder, which may determine whether patients have problem with urination or urine retention. So one way to do this is through ultrasound. It's non-invasive. Another way is by inserting a bladder catheter after they've passed urine to determine how much volume is left inside. Obviously, the non-invasive method is preferable because it causes less discomfort and less chances of complication. So usually we say, anything above 100 or 200 mils may be considered abnormal. But these measurements, we cannot make this judgment based on a single measurement. You need repeated measurements of clinical correlation in order to determine whether there is actually post-residual volume. At low volumes at least. So for evaluation of, we use this for evaluation of complicated urinary incontinence, because with the mixed urinary incontinence, there may be certain specific disease entities which may be quite complicated, like neurogenic bladder, where you can have both the bladder increased bladder tone, and also you also have the sphincter increased tone at various different times, or when patients have lower urinary tract symptoms or symptoms of outlet obstruction, or in patients with recurrent urinary tract infections, because residual urine may become a source for urinary tract infections. And another tool that is very useful, especially for patients who are still functioning well and who are able to comply to it, would be the bladder diary, in which you measure things like, what are the drinks that they consume, at what time, and then when they pass urine, and whether they have symptoms or not, and whether they have incontinence. This is a very quite reproducible tool, in the sense that if a patient records this, right, it is when you measure this over a span of 1 week, the measurement over the first 3 days usually correlates to the measurement over the next 4 days. But there's a large individual variation in what may be reported by patients, and therefore we can't give like what is normal, what's not. But this is again a very responsive tool. It's sensitive to change. You can notice it from the charting immediately, and it's a good measure of outcome, and can be used to diagnose urge incontinence. The value of a bladder diary extends beyond diagnosis or monitoring. It can also be therapeutic, because it also fosters behavioral modification, when patients can see the changes, how the changes that they do affect their own urinary habits. Another thing that we can use is a PET test, where you put a PET, right, and to determine urine loss. The thing about a PET test is that you need to standardize it. You need patients, for example, to drink a certain amount of fluid, and measure the PET again over a certain time period in order for it to be valid. So you can do a 1-hour PET test or 24-hour PET test. But it is really difficult to standardize this. Then urine FEME also has its value, because urinary tract infections can also lead to increased symptoms of incontinence. So in patients who are symptomatic, you want to treat a urinary tract infection, right? And therefore you want to do a urine analysis. On the other hand, if patients are asymptomatic and you do a urine analysis which determines that patients have features suggesting a urinary tract infection, we do not necessarily want to treat it, because we do not suggest treating, in older adults at least, asymptomatic bacteria, especially in those in the nursing homes, because there is no evidence that in treating these urinary tract infections actually improves symptoms of incontinence. It's a different story if they have symptomatic urinary tract infection. So another thing is urinary tract imaging. Is there a role in doing that to diagnose or to work out an incontinence? We suggest not to perform it routinely, because there's absent evidence, lack of evidence of clinical benefits if you do urinary tract imaging for the purpose of investigating incontinence. Next is something that we also do when it comes to continence service, which is a urodynamic study. Basically, it is when you look at the bladder or abdominal pressure, and you look at the volume, and you plot it into a graph. This is what we call a multi-channel urodynamic study. We don't do this very often, but we may choose to do this if we think that the results may determine choice of surgery. For example, in patients with prostate problems, or in those with mixed urinary incontinence, we really want to determine what the main problem is, or more complicated conditions like neurogenic bladder, or if you suspect some anatomical or urological issues. And usually this is done at the more specialized level, whether in the urological or rehabilitation side. So once we have worked out what type of incontinence the patient has, and determine the problems that are affecting it, then we go on to management. And with management, the aims are quite simple. It is to identify reversible causes, and then institute behavioral or physical therapy, followed by medical therapy, and then if all this fails, then consider whether any sort of surgical or interventional therapy may work. And subsequently, you need to think of a mechanism for feedback or monitoring. And I'm making a token mention here, but I think when it comes to incontinence services, if you're serious about creating one, then as with any other geriatric measures, right, that we want to involve the multidisciplinary team in these things. So in a continence service, you may consider, for the older adults at least, these multidisciplinary team members, a geriatrician, a continence specialist nurse, and a physiotherapist specialized in the pelvic floor, occupational therapists, pharmacists, and with the involvement of surgeons, gynecologists, urologists, or general or colorectal surgeon if needed. And this is actually quite an important thing to ensure or to help ensure success of continence programs. So first, of course, we treat reversible causes. There are many ways to do this, but I offer this mnemonic, diapers, delirium, infection, atrophic vaginitis, pharmaceuticals, psychological disorder, excessive urine output, stool, and reduced mobility. So when it comes to incontinence, you'd be surprised that, the bowel and actually the bowel and the urine is very, very closely related. So, if patients develop urinary retention, a common cause of it may be stool retention. And of course, these are the things that we can also act on. So that's the first step. Look for reversible causes and treat it. The second one would involve behavioral or physical therapies. So for more general measures, it would include things like pelvic floor muscle training or the pelvic floor strengthening exercises and alterations of fluid intake. And also for some patients, consider whether weight loss interventions may work. And for stress incontinence, where the problem is weakness of pelvic muscles, there may also be more intensive and supervised pelvic floor muscle training may help, and use of vaginal cones, weight vaginal cones, which actually help to strengthen the pelvic floor muscles. Pelvic floor muscle training, or what we call Kegel exercises, can be done not just for women, but also for men. And the general prescription that advise for patients with incontinence, supervised exercise, pelvic floor muscle training for more than 3 months, more than 8 contractions 3 times a day. And as with any other exercise programs, you grade it, you use the most intensive program that patients can do. And this can be done with or without biofeedback in a group or not. So if patients are unable to perform this, another way to do this is to use electrical stimulation so that, they can help to strengthen the pelvic floor muscles. Biofeedback would be things like this, inserting or putting devices which measure patients' ability to contract the pelvic muscles so that, they can tell whether, they are doing it correctly or not. And for other behavioral or physical therapy, like I said earlier, fluid intake modification, reduction of caffeine intake as it can increase the incontinence, and also bladder training. And for mixed incontinence, usually if there are many issues to settle, we try to treat the most bothersome symptom first. Either that or we combine therapies. For functional and urinary incontinence, which again, I mentioned earlier, this may be due to physical or cognitive issues. You want to remove any physical barriers that prevent patients from going to the toilet. So you may also want to consider, for those who are cognitively impaired and unable to tell when they are going to go to the toilet, to time their voiding. That is to bring them to the toilet at certain times and tell them, to pass urine then. This does not necessarily work all the time, but it may be useful to help to reduce the distress, by the carers who are complaining of, voiding or passing motion in the middle of the night. And if that fails, then another option is to use containment devices to prevent inappropriate soiling of the surrounding. So things like incontinence pads and condom catheter. But of course, when it comes to these things, the other question is patient's dignity. It may not be what we want to use as a first line. And for overflow incontinence or neurogenic bladder, sometimes because of inability to control their voiding, and for patients who are capable, we want to teach them how to catheterize their own urine. So intermittent catheterization may be an option. Another one, if we fail to do intermittent catheterization, would be to use the CBD to prevent incontinence problems. And bladder training, which is a form of physical therapy that will teach to the patient, involves doing certain specific habits in when going to the toilet. So for example, you empty the bladder in the morning, then you set certain times to go to the toilet and to void, and only make them go to the toilet at the designated times, because we want them to learn how to delay their urination and to suppress the urge to urinate. So the aim here is that every time they are able to go to the toilet at certain intervals, later you increase the interval of the bathroom visits. And so this is a behavioral modification. And you pair this with the physical one. Sorry, I was talking physical just now, which is the pelvic floor muscle training. And there are actually strategies that we teach patients, how to suppress the urge to urinate. So number one, when you feel the urge, stop everything, sit down. Number two, squeeze, give 5 strong pelvic contractions. Number 3, relax. Try to relax and distract yourself. And number 4, go to the toilet, but don't rush there because rushing will worsen urgency. And if the urge develops again, repeat these steps again. So these are the things that we advise patients to learn in order to suppress the urge to urinate. And the third thing that we do is medical therapy, which means we involves the use of medication, and that is dependent on the type of incontinence that the patient has. So for urge incontinence, where the bladder is overactive, things like antimuscarinics or mirabragon, which reduces the detrusor tone, may be useful, as well as alpha blockers. And for things like lower urinary tract symptoms because of BPH, things that treat BPH like alpha blocker or 5-alpha reductase inhibitors may work. You want to exercise caution when doing this because sometimes patients have, let's say, prostatic hyperplasia. They also have urge incontinence, and you find that they are on prostate treatment, alpha blocker, 5-alpha reductase inhibitors, and they're also on antimuscarinics. The thing about antimuscarinics is that they cause bladder relaxation of bladder tone, and they actually can increase urinary retention. And there is a selectivity of the antimuscarinic agents. Certain agents are more selective than others, but regardless, they are anticholinergics, so they can cause cognitive impairment. And alpha blocker, of course, is may cause postural hypotension. And again, certain types of alpha blockers may have lesser but not but still present risk of postural hypotension. I guess another thing to note is that the duration of time needed in order for the 5-alpha reductase inhibitors to exhibit its effect. It may take as long as 9 months before our finasteride or dutasteride starts to work on a patient with prostatic hyperplasia. And it only works for patients with enlarged prostate. And for stress incontinence, this SNRI, which is duloxetine, has been used for selected patients as second-line treatment, but the risks and benefits is questionable. And for neurogenic bladder, sometimes they use alpha blockers for sphincter tone imbalances. And when all these therapies, which is behavioral, physical therapies, and medication therapies fail, then you go to the more invasive procedures, which are the interventional therapies. Indications include things like this: when more conservative measures fail, urge incontinence persisting despite antimuscarinics, urinary incontinence beyond 6 to 12 months, and post-prostatectomy incontinence persisting for more than 1 year. And in order to consider, before you consider all these more invasive interventions, you want to perform a complete evaluation to balance the risks versus benefits of surgery. And obviously, you need to engage the specialists that are able to help you to do these interventions. So some of these interventional therapies that we can do include bladder wall Botox injection, sacral nerve modulation, continence balloons. I think we'll go through the pictures. Yeah, so bladder wall Botox is basically what it is, you inject the Botox on certain parts of the bladder wall to reduce the contraction of the bladder muscles and to relax so that you reduce the urge. And sacral nerve modulation is basically stimulation of the sacral nerves, which this intervention actually not only helps reduce urinary incontinence, it can help reduce fecal incontinence as well. So you put the probe into the sacral nerve and you connect it to a device which gives an electrical current, which you can adjust. And continence balloons are balloons that you place at the bladder outlet, which you can inflate with by manually, manipulating feeding ports so that you can maintain continence if you are leaking urine. And the similar concept in artificial sphincter, where you have a sphincter that surrounds the bladder outlet, and there's a reservoir that you place somewhere with a motor that you place elsewhere, where it's driven either by mechanical power or with electricity, which you use to control the sphincter, so that, you know, when you want to void, you let go of the pressure, and when you don't want to leak urine, you increase the pressure. The same concept here for sling surgery, where instead of instead of encircling the urine outlet, you sort of pull it at an angle so that it's more difficult for patients to leak urine. Which is also the concept of this birch corporal suspension, except that you use certain anatomical structures to help you to maintain the angle. Another thing that we can do is urethral bulking. Again, is things directed at the bladder outlet, where you inject an agent which actually bulks up certain parts of the urethra so that it's not so easy to leak. And if all else fails, we could also divert the urine elsewhere or do surgical interventions to increase the bladder capacity to help to reduce the cases of urinary incontinence. And now we'll talk about certain specific conditions. One is post-micturition dribbling, which mainly affects males, and it might actually be the most common lower urinary tract symptom in males, with prevalence reported between 5.5% to 58.1%. Prevalence increases at advancing age and may be associated with other things like erectile dysfunction. Treatment involves what we call urethral milking, which is that you press down onto the scrotum to at the point where there is the retention of the urine to help to pass that little bit of urine that's stuck there, or pelvic floor muscle exercises. Then neurogenic bladder is a neurological condition caused by various neurological insults, which is a bit complicated in that it can cause detrusor overactivity or underactivity. It can also cause sphincter overactivity or underactivity, and the sphincter and the detrusor may be out of sync, which may cause sensation of urinary urge but inability to pass urine, or it can be that they both work together and you just leak urine. So it is complex and it requires urological evaluation and input. Then atrophic vaginitis can also cause symptoms of urinary incontinence, and by physical examination, you should be able to determine, or with history also, dryness, irritation, pruritus, burning, and these can be treated by the use of topical estrogen. And pelvic organ prolapse, of course, like cystocele, rectocele, UV prolapse, may cause stress urinary incontinence. It's diagnosed with pelvic exam. And treatment is, again, the same things: pelvic floor muscle training, pessary, and surgical correction. And for those patients who undergo prostatectomy, their problems don't end there. Even if the prostatectomy is done because of lower urinary tract symptoms of obstruction, after the operation, they may have incontinence, which may be stress incontinence. And so it's about prevention, because this is intervention, right? So before doing the surgery, you want to prepare the patient for the surgery. And if needed, if there's persistent incontinence post-prostatectomy, then treatment involves all these things, the artificial slings or urinary sphincters, bulking agents, and pelvic floor muscle training. Next, just a very quick mention on fecal incontinence. So fecal incontinence is obviously very embarrassing. It is an unintentional passage of solid or liquid stools, and we can divide into three types. Just like urinary incontinence, we can divide into urge incontinence. We can divide into what we call passive incontinence, where patients are totally unaware that they have passed motion the stool, and fecal seepage, which happens unintentionally, usually after the patient has defecated. And the effects pretty much the same as with urinary incontinence, skin breakdown, psychological effect, increased caregiver burden, institutionalization, and increased utilization of healthcare, and may lead to social isolation. Prevalence is reported as between 2 to 36.2%, with and also increases with age and institutionalization and hospitalization. And of course, it may be that this is one of those conditions that patients may be very embarrassed to admit, and so it requires some sensitivity in elucidating these symptoms. It's associated with pretty much the same things that cause urinary incontinence, and you may have both together, right? Pelvic floor muscle weakness, impaired cognition, functional mobility issues, neurological disease, diabetes, and in this case, more prominently, gastrointestinal issues may cause more of this fecal incontinence. So diarrhea, constipation, inflammatory bowel disease, and post-surgery. So yeah, fecal incontinence makes sense if you are talking about diarrhea, but we also talk about what we call spurious diarrhea, right? Which is that when patients, because of severe constipation, only the liquid or soft parts of stool can leak out, and it may seem like patients having diarrhea, but actually the underlying cause may be because of constipation. So in treating fecal incontinence, we still need to make this distinction. Is it because of diarrhea or is it because of constipation? And evaluation actually follows more or less the same concept, right? You do history taking, you look for comorbidities, you check cognition, function, mobility, medication, and try to determine the nature of the incontinence. You follow that up with a physical examination. We focus on the abdomen and rectal and maybe neurological. And you do further testing as appropriate. We focus on the GI system. So as I mentioned earlier, because patients may feel embarrassed to admit that they have fecal incontinence, you have to treat this with some sensitivity. They may talk about accidental bowel leakage, or they may not say that they have incontinence. They may just say as they have diarrhea. So we want to be sensitive about that. And management, again, is the same thing, reduce coffee, increase fiber, more or less the same thing. And if patients are on oral nutrition supplement, as in those patients who are on round tube feeding, right, they're on milk supplements, right, you get it very common, they have diarrhea, and so you want to evaluate that as well. And you want to consider giving medication as appropriate for constipation or for diarrhea, and treat underlying cause if we can identify it, usually due to medication, constipation, or some sort of bowel inflammation, colitis, or infection. And in this case, you may want to consider getting, depending on what the condition may be, gastro or colorectal consult for co-management. So we are at the end of the talk, actually. So in summary, incontinence is the inability to control one's excretory functions, either bowel or urine. And it's a frailty syndrome with multifactorial etiology, of which the prevalence increases with age. And being of multifactorial etiology is best managed in a multidisciplinary team. Urinary incontinence types, urge, stress, overflow, functional, and mixed. And management of urinary incontinence involves identification of reversible causes and the behavioral of physical therapies, which we've mentioned, medical therapy, and if that fails, surgical or interventional therapy, and subsequently feedback and monitoring. Fecal incontinence types are passive incontinence, urge, and stool seepage. Management more or less follows the same concepts as that of urinary incontinence, with more emphasis on gastrointestinal diseases. And that concludes my talk.
Okay, thank you, Dr. Lim, for the very enlightening talk. I'm sure we all learned a lot from this. We welcome any questions from the floor. You can either switch on your mic and ask, or if you're a bit shy, you can type in the Q&A box. I think we have our first question from one of our panelists, Dr. Lim. So Dr. Kaur asked that, do patients with benign prostatic hypertrophy require long-term alpha blockers or 5-alpha reductase inhibitors? Because many patients that we see are on a long list of medications and they are set on continue this as long-term. So, yep, your input, please.
Okay, I think I'll talk about the 5-alpha reductase inhibitors first. When it comes to 5-alpha reductase inhibitors, when we're talking about lower urinary tract symptoms, which is prostatic hyperplasia, is actually efficacious for those with demonstrated prostatic hyperplasia, meaning those with enlarged prostate volumes. But we see that people get started on the medication just by because of the history of urinary retention alone. So I guess the answer here is that we need to determine whether there's evidence of increased prostate volume and that if there's no increased prostate volume, it may be safe to stop the 5-alpha reductase inhibitors because it may not show much effect. The second thing is that, as I mentioned earlier, the duration of action, it takes about 9 months before finasteride or dutasteride takes effect. So it is not useful in the acute setting, in treating urinary retention. In other words, there's no hurry in starting the 5-alpha reductase inhibitors. You won't see immediate effect. On the other hand, with the not 5-alpha, sorry, the finasteride or the dutasteride, yeah. So now for the alpha blocker, of course works faster. So when patients have acute episodes of urinary retention, you see them being started on alpha blockers. But as with other things, right, we didn't talk about we only talk about incontinence. We didn't talk about the inability to pass urine. In other words, urinary retention. But for urinary retention, again, you also want to look for reversible causes first, right, before you start to do all these things. And a common cause of urinary retention is constipation. A lot of impacted stools at the back portion of the rectum, right, pressing against the bladder. So we want to treat all these things first. And so even those patients who get started on alpha blockers inpatient, sometimes we do manage to stop their alpha blockers if we don't think that it is necessary. As for long-term use of it, I guess when it comes to the geriatric population, we do have patients who suffer from adverse effects from these drugs like alpha blockers, causing postural hypotension or giddiness or falls. And in those situations, we do manage to stop patients on the drugs, but not always, because it always comes down to the patient's outcome or their perception of their well-being. And if for some people, the inability to pass urine is a very important thing, and sometimes despite our advice to stop drugs, the drug they do not want to. And of course, there are some whom, after we stop the drugs, they get worse symptoms and we have to start them back on it again. There's another thing about it, which is that when it comes to alpha blockers, there are also some alpha blockers which may exhibit less chances of side effects or postural hypotension. And so, in certain patients, you may want to choose those drugs instead. So to my knowledge, alfuzosin and also basically doxazosine may be the preferred, tamsulosin and alfuzosin may be the preferred agents to be used when it comes to the reducing incidence of postural hypotension. But reduced incidence doesn't mean absence. That means they can still get postural hypotension from these drugs.
Okay, thanks, Dr. Lim. But when you say about determining the prostate size, do you mean clinical or all have to go for an ultrasound?
Well, unfortunately, clinical determination of prostate size is very unreliable. We are talking about objective assessment like ultrasound prostate volume, more than 30.
Okay, thank you. We also have some questions from the floor. First would be, can desmopressin be used in urinary incontinence?
Okay, can desmopressin be used in urinary incontinence? I guess it depends on the the etiology of the incontinence, right? But I don't think we do that as a standard. But again, it depends on what are the things that we are trying to treat. So the main thing is that we want to treat the underlying cause. Yep. I see another question there. So in overactive bladder, anticholinergic agent is used as a first-line agent for Alzheimer's patient. That is rivastigmine and donepezil with incontinence. Can we still use the anticholinergic agents? So in other words, whether the cholinesterase inhibitors
Dr. Lim, I think having some connection issue. Probably have to wait for a while. Priscilla, maybe you want to see whether Dr. Lim is trying to reconnect.
Okay, doctor.
Yeah. Okay, I think it's reconnecting. Thanks for your patience, everyone. Technical issues a bit. Okay, Dr. Lim is back. Oops. The Lim say he had a lightning storm there knocking him off. Okay, I think he's trying to. Okay, are you back, Wanji? You need to unmute. You are muted.
So
Okay,
sorry,
good.
the lightning knocked out my internet connection. I think yeah. Where was I? Something about
The
anticholinergic.
anticholinergic.
Yeah. So not to my experience at least, has there been a need for us to stop the specifically the donepezil or rivastigmine because of urinary issues? Yep. Were there any other questions?
Okay, I think you broke for a while. So I think your summary is you should not use, right? You broke for a while here there.
So sorry.
Because you broke when answering, you broke for a while. So the short answer is shouldn't use, right?
You mean the anticholinergic agents when patients have urinary retention?
When in Alzheimer's, for Alzheimer's patient, yeah.
Okay. Well, the thing is that I've not had the need to stop drugs because specifically because of urinary retention before. But usually when we make the consideration, it is I think we do make this consideration when there is a need, but we consider in isolation from the cognitive issues itself. Because when patients have urinary retention, usually you can find some reversible causes, and we don't have to resort to stopping the drugs.
No, I think Dr. Lim's question was in overactive bladder, right? We use anticholinergic agents to treat. So for
sorry,
Alzheimer's
yeah.
patient, can we still use it? Can we still use these agents?
Sorry. Okay, I think I must have not read the question properly. So the question is, if you're on anticholinergic agents already, whether you can still use the anticholinergic agents that we use for treating Alzheimer's disease, right? Is that the question?
No,
Because
I think the question is, can you still use anticholinergic agents in Alzheimer's patient who have overactive bladder?
Oh, yes. You can because the agents that we give, which is the anticholinergic agents, which is what you call that, anti-muscarinic selective or M3 selective, right? They are not supposed to affect too much of the other areas, but of course they can still have an effect. So we can still consider using it, but I think a thorough evaluation is needed with the before we consider whether those agents are appropriate. And again, those are not the first things that we will consider. That is that not everyone with urinary urgency, we will straight away give them these agents. So and those who are already on treatment, we can still use it, but with caution, with judicious. Yeah.
Yeah, I think we also have better agents nowadays, more selective ones, which maybe have less cognitive side effects as well, such as your beta-3 agonists, etc. Right?
Yeah.
Okay.
So the thing about the beta-3 agonist is, although we do not have much data of its use in men, but it's still an agent that we can consider for use in men. It's just that it's more we have more evidence of its efficacy when used in women.
Yeah, and definitely lesser risk than your typical anticholinergic agents in
Yes,
dementia.
definitely.
Yeah. Okay, but still, we all geriatricians always like non-pharmacological ways first before any medication.
Yeah, so we don't always think about medication first, and the thing about consideration is that it all again goes on a case-by-case basis. So can we say that it's an absolute contraindication? I wouldn't say so. But when we are considering the overall effects on someone else or a patient, right, there are actually a lot of other factors that we consider.
Okay, great. Any more questions, guys? Please feel free. I know it's not a very common thing you'll see day to day, but which brings me to the question also, should we actively screen or ask our patients for all our older patients that we see in clinic, irrespective of what they're seeing us for?
Can you hear me? Hello?
Yes, we can.
Yeah, the lightning struck again. Yeah, so sorry. Yeah, I think, let's continue.
Yeah, so I was asking, so I think many of the audience are sitting in the clinics every day, maybe seeing patients for other problems. So should they actively screen for incontinence, as in ask them specifically, irrespective of what issues they are coming for, all the older patients, should we actively ask them?
Okay. In a busy set. Hello.
Yes, we can hear you.
Okay, right. So in a busy clinic setting, I wouldn't, recommend routinely asking patients about this. But when it comes to a patient, right, because this is a frailty syndrome, and what it means is that when patients have this symptoms, it warrants further evaluation. So, if you incidentally come across it opportunistically, it may be an indication that you require further evaluation. But to screen patient for continence in the absence of an established continence service, may not be very an effective way of treating this problem. However, by just looking at the patient's other factors, we may find patients with the tendency to develop incontinence. So it will be patients who have other frailty syndromes, those with falls, or those with cognitive issues, those with functional or mobility issues. Perhaps these are the patients that you may have a higher yield, in assessing for the continence. So not routinely for everyone, but for patients who may fit certain indications.
Yeah, I think I agree with you on that. So I think the utopian dream is hopefully one day all hospitals will get incontinence service, then we can treat everyone holistically. Any more questions, guys? I think we're almost time. If no more questions, Priscilla, should we end this?
All right. Thank you. Okay, doctor. There's no more question. I think we can end this session now. So I think thank you, Dr. Lim and Dr. Lau, for the interesting topic. We have learned so much in this session. See you all next week.
Okay.
So sorry about the thunderstorm. That's a common feature in Taiping. So
Yes.
Yeah. But all of us are so hot here, you get a storm. Okay. Okay. Thanks, everyone. See you next week.
okay, see you
Bye.
all. Bye-bye.